Let's talk about reabsorption at the loop. All right, so your loop of Henle, or your nephron loop if you prefer. This is responsible for reabsorbing about 50% of your water, and that is 50% of the water that is left. Okay, so if we go back real quick, we just said 60 to 70% of water. There's not 50% left. We're talking what is left. Okay, we can reabsorb 50% of water that is left. We can also reabsorb up to about 67%, 2/3 sodium that is left, 2/3 of chlorine ions that are left. Okay, so again, still remaining in the filtrate. Okay, so again, if you are just looking at these numbers too quickly, things aren't going to add up. So again, please remember that we've already taken out a bunch. We're taking out this much more of what is left. Okay. All right, so counter current multiplication, okay, which apparently is hard to say. What is happening? We are exchanging things. Okay, we are exchanging solutes to adjust how filtrate, the salinity of filtrate. So basically, how salty your filtrate is. We don't want too much solute to remain in the filtrate because we just talked about reabsorbing all the things. One of the functions of your loop is to help maintain the correct solute concentrations of the filtrate itself. So water, we've talked about reabsorbing water. We can continue to reabsorb water, specifically here in your descending loop. We do this via aquaporins. Okay, these are specific channels that only allow water to move through them. Now, sodium and chlorine can also be reabsorbed. If you remember sodium and chlorine, sodium is coupled with water, chlorine was coupled with sodium, so all of these things are going to get reabsorbed together. The sodium and the chlorine, however, get reabsorbed at the ascending loop. Okay. Now, there is a drug, it's called Lasix, okay, with an X. Okay. This is known as a loop diuretic. Basically, it inhibits sodium reabsorption. What is going to be the consequences of that? Well, if you cannot, or if you just are not reabsorbing as much sodium, you are also not going to be reabsorbing as much water, which means that your blood volume is going to go down, which means your blood pressure is going to go down. Okay, so that might be a treatment for something. All right, our last part of the tube, your distal convoluted tubule. This is responsible for reabsorbing pretty much anything useful that's left in the filtrate. Okay. However, this is regulated by our needs, so we're going to use hormones. So we're not just going to reabsorb everything that we can just get our hands on. We're going to determine, is there a need for us to reabsorb this at this point? So water, any water that's possibly left in the filtrate at this point, do we still need more water? Maybe. If so, the reabsorption will occur via osmosis as well as aquaporins, and we just mentioned aquaporins were just specific channels for water transport. So what's happening here? Antidiuretic hormone, ADH, okay, is going to insert your aquaporins into your distal convoluted tubule, okay, when osmotic pressure goes up. Okay. This helps retain water to dilute your blood if it gets too salty. So we just talked about countercurrent exchange, making sure we are regulating the salinity of the filtrate. Well, now we're talking about helping make sure the blood doesn't get too salty. Okay. This is facultative water reabsorption. Okay, if the ADH is present. Concentrated urine will be formed because you've taken most of the water out of the urine and you've put it back into the body. However, if the ADH is absent, okay, if you're not taking up the last little bit of water, then you will form more dilute urine. Facultative water reabsorption, what does that mean? That really just kind of means we have a need for this. Okay. Remember, obligatory was you're reabsorbing whether or not you needed it. Facultative is, we need just a little bit more water to stay hydrated. We'll do that reabsorption here. Now, aldosterone also plays a role. Water will passively follow sodium reabsorption. And remember, that's what aldosterone regulates. It regulates sodium reabsorption. So ultimately, it regulates water reabsorption as well. We can also inhibit these things. So reabsorption is inhibited by caffeine or other diuretics. It's inhibited by glucose, which affects your osmotic pressure, your osmotic, it's an osmotic diuretic. And alcohol inhibits ADH secretion. Okay, so again, if you're not producing ADH, you're going to make dilute urine, and if you're inhibiting ADH from alcohol, you're probably going to make a lot of dilute urine. Okay. Now, if you reabsorb at the distal tubule, you'll move into the peritubular capillaries, and you'll notice that this pathway is basically the same. Okay. All right, a little bit more on reabsorption at the distal tubule. This is responsible for helping reabsorb any useful solutes that are left in the filtrate at this point. But again, don't forget that this is now being reabsorbed based on need. Okay, not really want. It's based on need, so not really obligatory. Okay, it's do we need this? So one of the main driving factors of this is your blood pressure. Okay, so sodium, okay, specifically, we can reabsorb that via facilitated diffusion. We've got those sodium channels, that's fine. Why might we be reabsorbing extra sodium? We might actually be after the water. Okay, so remember, if you're reabsorbing sodium, water's coming right along with it. Aldosterone can be released to increase sodium reabsorption, which increases water reabsorption. This will ultimately have an effect on your blood volume, which affects your blood pressure. So if your blood pressure is too low, okay, we can secrete aldosterone. We can reabsorb sodium, which reabsorbs water. That water reabsorption increases your blood volume, which ultimately increases your blood pressure. Okay, we've activated the whole RAS system. Okay, this is inhibited by caffeine. Okay. Also, just side note, if you are reabsorbing calcium, you are secreting or getting rid of potassium ions. Okay, that's just kind of something to kind of keep in the back of your mind. That'll come up one or two more times in a couple of other places, but just kind of FYI, if you are reabsorbing sodium, then you're getting rid of potassium. And then calcium. Okay, we can also do some calcium reabsorption in the distal tubule if we have a need for it. This is controlled by parathyroid hormone and calcitriol. Okay, so this can help us increase our blood calcium levels. We have talked a lot about the uses of calcium in your body. Just for example, muscle contraction, action potential firing, blood clotting. Calcium is kind of a big deal, so we will do whatever we can to make sure we do not get too low on your blood calcium levels. All right, last but not least, we have tubular secretion. Okay, this can also occur at any point on the renal tubule, the proximal, the distal tubule, or even the collecting tubule. Okay, your solutes. Okay, we're going to add them to the filtrate from the peritubular capillaries. So everything we had been talking about with reabsorption, we were taking things from the filtrate and we're putting them into the peritubular capillaries. Now we're talking about taking things from the peritubular capillaries and we're putting it into the filtrate because we want to get rid of them. Your body doesn't need them. Okay, this also helps maintain blood pH. And it helps get rid of wastes that were not filtered during glomerular filtration. Okay, if you are a solute or a substance that is tubularly secreted, you're going to go from the tube into somewhere, for example, the distal tubule or maybe even the collecting duct itself. You'll go down the renal papilla, minor, major calyces, pelvis, bladder, urethra. You will exit the body. Okay. What might we secrete? We could do things like potassium. Okay. Aldosterone stimulates potassium secretion. Why? Because aldosterone stimulates sodium reabsorption. We just said that if you're reabsorbing sodium, you're getting rid of potassium. Well, this is how you're going to get rid of it. You're going to do tubular secretion. You're going to put it into the distal tubule. Now, potassium is your major intracellular electrolyte, and it can be filtered in as well as secreted. Okay, so this really plays a role with the aldosterone specifically. You can do too little or too much of this, though. You could suffer from hypokalemia, which could develop through insulin use. Okay, so if you're diabetic, or you could suffer from hyperkalemia, which can cause cardiac arrhythmia, so heart problems. So we really kind of want to keep track of good potassium levels. Now, urea and uric acids, these are waste products of metabolism, and these can both be either secreted or reabsorbed based on need. Creatine, this is another waste product. This one is created during muscle physiology, so muscle contraction, so not really metabolism like the last two. Again, can be filtered as well as secreted. We can actually use this to calculate your glomerular filtration rate because creatine is not typically reabsorbed. Okay, so however much is we can calculate how much is being created, and then we can calculate how much is ending up in the urine, and we can use that to calculate your filtration rates. Now, hydrogen. Hydrogen ions, we have learned that those help you maintain your blood pH because hydrogen ions are basically acids. Secretion at either the distal tubule or the collecting duct is stimulated by aldosterone. Okay, this ion, hydrogen ions, specifically play a big role in respiratory acidosis and alkalosis. Okay, so if you are suffering from respiratory acidosis, okay, so your blood has become too acidic, you've got too much acid, and it is a respiratory problem, so maybe you are hypoventilating, you aren't breathing out enough CO2. We can kind of compensate for that. What is going to be the compensation? Your urinary system. You're going to have to do some sort of metabolic compensation. That compensation is going to be increasing hydrogen ion secretion, and reabsorption of bicarbonate ions is going to increase as well. Why? Because bicarbonate ions act as a base to help us alleviate our acid problem. And then we also have the opposite, respiratory alkalosis. Perhaps we are hyperventilating. Our blood has become too basic. Our compensation, again, who is going to fix our problem? It will be our kidneys. How do we fix an alkalosis? We are going to decrease hydrogen ion secretion, so we are going to not get rid of as much acid, but we are going to decrease reabsorption of bicarbonate, so we're not going to keep around as much base, okay, because we already have a base problem, okay. So that will fix our alkalosis. So respiratory acidosis, what's the fix? It's metabolic alkalosis. If you have a respiratory alkalosis, what's the fix? It's a metabolic acidosis. All right, our picture, you can see where all these things are happening. Filtration only happens here at the glomerulus, but reabsorption and secretion happen at the proximal tubule. The loop is really just dedicated to reabsorption, and then your distal tubule and your collecting duct can do both reabsorption and secretion.